This is an exciting innovation for pharmacy in that it's the first time in a while anyway that Glasgow's had the opportunity to make a direct referral in to another service from community pharmacy. It gives the pharmacist or the pharmacy teams an opportunity to direct somebody straight to a point of care, as opposed to saying, well, you'll have to go away and phone NHS24 or go and phone your GP practice. But in order to explain this in much more detail as to what the FNC is and what it does, I'm going to hand over to Ed, and he's going to explain what the FNC is, what they do, and how the relationship between community pharmacy and the FNC can work for both our benefits. Ed, over to you.
Thanks, Pamela. So the Flow Navigation Centre was set up in the end of 2020, and the Scottish Government asked every health board in Scotland to set up a Flow Navigation Centre. Now, for those of you that work in Glasgow and only need to get to understand this Flow Navigation Centre, that's perfect. If you're kind of looking at things more nationally, they all work completely different and are a bit of a riot. I know you wouldn't believe that of the Scottish NHS, but in Glasgow, our Flow Navigation Centre is predominantly nurse-led by advanced nurse practitioners. There is some medical input, but not an awful lot. So we're a team of advanced nurse practitioners, predominantly from emergency department and minor injury unit backgrounds. And we have some paediatric advanced nurse practitioners on the team as well. And the aim of our workload was predominantly to look at referrals that could be coming towards a minor injury unit or emergency department and provide a virtual assessment for those patients in the first instance. And in the early days, all of that came via NHS24. But we're at this point now where we're expanding to accept patients directly from Scottish Ambulance Service. And now we have this new pathway for community pharmacy, which is quite exciting. The whole purpose of these patients coming via us initially is that we can do the virtual assessment, which most of the time we tend to use video. We do prefer to do a video assessment, but that shouldn't put you off referring somebody. If it needs to be telephone, that's fine. We will also do that. And it was part of the COVID response was to kind of limit who was coming to the front door and to try and streamline people coming to the front door as best we could. So since we opened in December 2020, we have consistently managed 30% of the patients referred to us by other healthcare professionals at home. They didn't need to come to hospital at all. So that's a big hit. That's been a lot of people over the last year and a bit. But those that do need to come to the hospital, be that ED or minor injuries, we can streamline their attendance to be beneficial for both the service and for the patient. So at the time of doing the virtual consultation, we can look live at what the receiving unit is looking like. And if it's something like somebody needs a tetanus injection and the local hospital is absolutely burst at 8 o'clock at night, we can schedule them in for the next morning to come in, be seen within a kind of 20-minute window, and then leave and get the care that they need. As part of our evolving service, Charlene at great pain has managed to get us set up with Adastra, so we can now issue prescriptions to community pharmacies, which wasn't something I thought we would really need very much, but I see things coming off most days now for it's usually straightforward antibiotics and pain relief for patients, so that's been another useful enhancement. And I know that we're starting small key with this pathway receiving in from community pharmacies, but I think the long-term vision is that we can also send some form of electronic referral back to community pharmacy where we think that that would meet the patient's care need, and we can give guidance on what we think is required. Have I said enough? So the whole purpose of taking on this we're looking specifically at the moment at minor injury type presentations, because I know they walk into community pharmacy in their droves, and I'm sure that a lot of them have all their care needs met there, but there are another group that go on to need referral to hospital for different types of treatment. So we would be keen that rather than have them directed to the minor injury unit, we would be keen to have them directed to us, so that we can see who we can manage without hospital, and the ones that indeed do need to come up, we can schedule to the right service at the right time for the service and for the patient.
So I think it's important to say that this is a service that runs from 10 a.m. to 10 p.m. every day. So patients can potentially be contacted. Now, correct me if I'm wrong here. The idea is that the patient will get a call once you've made the referral, as the community pharmacy's made the referral. The patient will get a call back within 4 hours, and that potentially could happen even though the FNC is closed. Is that right, Ed? Yeah.
So I think at the point where the telephone call is made, you'll speak to a member of the admin team, and they will be able to give a time that that patient will be receiving their call back. And that could be, our last appointment times are 9:30 at night. So after 9:30 at night, it might be a case of the patient's just advised to come up to hospital, or given the option to wait until the morning, and we'll pick them up again when we reopen at 10 a.m. in the morning. Although Margaret is currently putting forward a business case that we are a 24-hour service sooner than later, but at the moment that's a wee bit away. So if it's at the very end of the night, they'll be asked just to come up to the ED or to wait until the morning for a call back. But yeah, I think at the point that the referral is made by telephone, we'll be able to give an approximate time to tell the patient to expect their call. So
I suppose sorry, I didn't mean to talk over you. I suppose just to say, as Pamela was saying there, and Ed, we are at this point in time 10 till 10, with the last call being at 9:30, 7 days a week. So I suppose it's just to emphasise that this isn't just an out of hours service for you guys. This could be a service throughout that time period from 10 a.m. in the morning. If you've got patients that pitch up that you feel you might want our advice and support with. So that's not just an out of hours service or weekend service for you guys.
And it is things like, do I need stitches in this? I've had a bite. Do I need a tetanus? I've cut myself. I'm worried it's infected. That kind of thing, where you could direct them to the GP, or you could direct them to the minor injuries. But this is an option for your patients that means that they'll get an assessment and appropriately directed, either for self-care or. And they may actually end up coming back to you and saying, right, I've spoke to the ANP and they've said, what I need to do is take some paracetamol and put out a plain dressing on this or whatever, and then you'll be able to do that under pharmacy first. You can record the consultation under pharmacy first, so you'll get the credit under pharmacy first for the consultation. And hopefully you've had a chance to have a look at the paperwork I sent out end of the week before last, just before I went on holiday. I gave a couple of pro formas there just to make sure that you get all the right information and make sure that you don't refer inappropriate people to the service, because it's only for people aged, is it 5 and over, Ed? Yeah, so young children can't be referred to the FNC, but anybody 5 and over can be referred. And so I suppose it's just to give you that guidance to make sure that when you make the phone call, you'll have all the relevant information that you'll require, that the call handler will ask you for. And it is a call handler. It's not a clinician that you will be speaking to. It's an admin person who will take the information and, like Ed says, will actually let you know how quickly the patient should expect a call back from the service. So you're able to sort of say to the patient, right, I can't deal with you. I think you need to be seen by somebody. I'll refer you to this service. I'll give them all your details, but hang on a minute until I've made the phone call. Then say, right, they should call you back within whatever the time frame is that you're told. You give them the patient information leaflet, which hopefully explains exactly what Ed's just explained there to them, and they can actually just go home and wait for the call to come back. They don't need to go up and sit in a waiting room for several hours, which in this day and age, when we still have COVID around, is not a good thing. And these waiting rooms can be incredibly busy. And if I'm right, Ed, you've got the opportunity to direct people straight into secondary care services if necessary. So it actually is a much smoother and better pathway for our patients, and it also gives us, as a profession, as a pharmacy profession, the opportunity to make these referrals without having to send them off. Without having to send them off around the NHS 24 loop, which I find quite frustrating when you know that they probably do need something you need to be seen for stitches or whatever, but you've got to go off. The patient needs to phone NHS 24. They need to no doubt wait for a call back, and that adds hours on to that patient's journey, which could be absolutely shortcutted. Shortcutted, is that the right word? And you know, it could be made much more smooth and quick by using this process. So I suppose the question is there any questions about this? I mean, the hope is we'll go electronic, and that's why Charlene's here, and we'll be able to use the DASTRA eventually, so that actually you'll just go on and fill in an electronic form instead of having to make a phone call. But we're a wee bit away from that, because as always with IT, which should make things better, it always seems to make things a bit more complicated. So Mark, you've got your hand up.
It would help if I went off mute. I've got two questions on what I've heard so far. I think it sounds like a great service and a great advance in the way that we can help, and to your point, Pamela, streamline the patient journey, which ultimately is what we're looking to do. And yeah, frustrating being on the end of where we've got to put them back into the NHS 24 system. So probably just to clarify and just to double check that pharmacist phone, says we've got it, speaks to the admin, and we're given a time frame. Clearly from experience, that would be much better than saying you've got a 4-hour window, because probably the likelihood of someone like that, I'm not waiting for 4 hours, I'll just walk up to wherever, or I'll go down to the GRI or wherever, because I'm not hanging around that length of time. So probably just to even give a wee bit of clarity, like, is it like does it depend on the different scenario? Is there an algorithm that you go through that then determines this could be a 4-hour call, or this might be a 1 hour, or is it just actually when availability of appointments? So a wee bit of clarity in that one. And in the other part, and again, when we're doing, transposing information or giving information, there's always that chance that something goes wrong and the digit of the telephone number goes wrong, and I'm that patient, I'm told I'll get phone called at this time and we don't. And I see in the patient information sheet that it gives the 119 number. I take it there's not, again, another direct number that we could go back and say, I was expecting a call from Ed at whatever, I've not received, I don't know whether they've got my number wrong. Again, just to try and make that journey seamless, and being aware that there's probably potentially going to be some situations where we get that information wrong. Someone gives us the wrong digit of a mobile or whatever.
Ed, I'll leave you to answer those ones.
Yeah, I can answer both of those, hopefully in a well enough fashion. So the first one, we have so many slots per half hour. So I think actually, I don't think that you'll be given a time frame. I think you'll be given a time when you call. So it'll be 11 or 11:30 or 12. So it'll be a time on the half hour. And if we haven't called at that time, it's just because we've got a bit behind, but we tend to run ahead, not behind on the whole. And your second question, when you're actually speaking to the admin, so they're bringing up our hospital system, so they're booking the patient in as they speak to you onto our TrackCare hospital system. So I'm 99% sure that most of these patients will be in existence and all those details will be there, and it's a confirming thing you're going through. So we probably have their home number, their mobile number, and their partner's number, and whoever else is their next of kin or their parents. And once we've got that, we've got a clinical portal as well that'll also hold spare numbers. So I imagine that even if there was an error at that stage, our system would correct it.
Yeah, that's just reassuring. So that's good to know. Thank you, Ed.
Any other questions? Laura Ann or Uzma, as the people in the front line, have you got any question? Uzma?
Yeah, my question is just that, so obviously because we're in Victoria Road, the Victoria Infirmary is the closest hospital to us, so do have a minor injury unit where it's just like a walk-in clinic. So if I have somebody that comes in with a wound that I think that needs addressed, I would probably refer them to the minor injury unit because it is just a walk-in. Would that not be a quicker service for the patient rather than having to, like then fill out this form and wait for a call back for them to get referred to that service anyway?
So yeah, I used to work in the Victoria Minor Injury Unit in my previous job. So NHS Greater Glasgow and Clyde is trying to completely eliminate walk-in patients for minor injuries. Now that's a bit of a 10-year plan. That's not something that's going to happen soon. But It will probably take longer if the patient self-presents and walks in. They frequently have a 4-hour wait to be seen for first assessment at the Victoria Minor Injury Unit. Whereas if we have done a virtual consultation and arranged a time for them to go, the plan is that they'll arrive at that time and be taken pretty soon after that time as a scheduled arrival. So this should be smoother and quicker. I know it kind of feels a bit counterproductive if that hospital is on your doorstep, but what we're trying to do is get away from patients self-presenting at the front door unless they're in a life-threatening emergency.
So I suppose it's a bit like having the fast pass at Disneyland, isn't it? Where you get to skip the queue, or it feels like you get to skip the queue because you've actually already been assessed and you're straight in for treatment. Is that right? Yeah.
Yeah.
And as for the form, you don't have to fill the form in. So the forms are there just to help and guide you and make sure that you've asked all the relevant questions, but there is no necessity to use it. There's no necessity to fill it in, and we don't want to see them. We don't want you to send them in. It's really just there for your own use. There is, however, a very short online questionnaire, and that's really just because it's a pilot. We need to gather some information and evidence, and in particular, we're interested in people that have these. So there's only these 2 clinical scenarios that we're interested in at the moment, although the FNC deals with a much wider range of patients. At the moment, because it's a pilot, we're only sticking to 2, which is the minor injuries type presentation, including bites. And then there's the sort of acute eye problem, especially if the community optometrists are shut, because obviously that would normally be your first port of call, and we would still expect you to follow that first port of call if that's what you would have done. If, however, the optometry practices are closed for whatever reason, then this is where the FNC would come in, and it's for an acute presentation. And we need to understand, if somebody has walked into your pharmacy and has one of these 2 acute presentations, but for whatever reason you don't refer them to the FNC, then it would be interested to know why you didn't, just so that we can understand if the pathway needs to be tweaked or whatever. So I suppose that's the that's the plea for you to filling in that, and it's literally, I think it's 4 questions, and the first one's your contractor code, but that's just to know where in the city you are. That's really all we're interested in, is and where have the people walked into you, so that we can understand where that demand is coming from. So it's not about, the contractor code A has done more than contractor code B, and it's not about that. It's just about the locality, about where that person has actually turned up. So that's the reason for doing that. So hopefully that makes sense. So I think, yeah, sorry.
Just it came into my mind, just a little bit more information about the minor injury unit, because they have such high waiting times at the minute, so they quite often start turning patients away at 4 or 5 o'clock in the evening because they don't have capacity to see anymore. So if the patients come through us, we will know that, and we'll take that into account when choosing their destination. It might be that we bring them to ED instead if they need seen that day, or we bring them up in the morning. Certainly the front doors of our hospitals are, this has been recorded, so be careful what I say, but they're just broken at peak times at the moment.
As a community pharmacy can be as well, but this gives you something to do with the patient, as opposed to just saying, go off and phone NHS24, which for me feels a bit more professionally satisfying. Scott, and then Laura Ann.
Mine's a bit more of a wrap up, Pamela. Laura Ann's probably got a much better question than me, so I'll let her go first and then come back to me.
Okay.
Thanks. So 2 questions. One, first of all, just to double check, do the patients have to be registered with Scottish GPs or anything like that? Just down to the fact we see a lot of tourists in the city centre where we are. Is this suitable for any patient? And the other part of my question was sort of to do with, again, the sort of population we see quite often in my store is your sort of drug user service clients. So quite often, if they do have wounds, they can be sort of chronic wounds. And I know, again, I've had a look over the forms and it does mention worsening of wounds and that sort of thing. Again, I know a lot of the issues that these guys have with accessing healthcare sometimes is to do with that communication barrier with, having a mobile phone number, the answer, etc. Is there any sort of provision for, that sort of population separately, or do we just sort of try and see if they're able to engage with the service, or do you have any thoughts on that?
So back to you again, Ed, for the first bit anyway.
So the first bit, certainly around the tourists, that's no problem. We can get them booked in. I guess we do need to be tighter with phone numbers and things for them because they probably won't be on our local systems. So that's where we need to check and double check that we've got the contact details, so we might not be able to trace them. And your second question, that's more complex, isn't it? We are very much the virtual emergency departments. If these are ongoing chronic type wounds, then these group of patients should be directed towards healthcare in places that deal with this, if that's GP treatment room or elsewhere. If you think that there is acute deterioration in them, or they're becoming cellulitic or infected, then we would be happy to take them on. I'd probably rather, I'm being recorded again, but I'd probably rather you erred on the side of caution and let us speak to those patients initially. If you're in doubt, we're happy to do that. That's why we're here. We're providing that virtual consultation. As to how effective our consultations might be with that particular client group, let's see, I guess. Let's see.
So I suppose the answer is, if you can get them to engage virtually with it, then you should try and get them to engage with it. I think that's the answer that I'm hearing. Margaret?
I was just going to say that exactly. I think we just try and include them as part of this pilot, and then we can take it from there, because obviously we're going to evaluate this as we're going along, and then obviously if we need to make adjustments to this pathway for specific patients or specific conditions, then that's what we will do as we go along.
Brilliant, thank you. Scott, do you want to do your wee summing up now?
Yeah, I thought I'd let all the proper clinical people go with their clinical questions, and then I could come in with a managerial one. So Pamela, in advance, apologies for all the store numbers that you'll get instead of contractor codes. If I can help with any of that, let me know. Just a massive thank you really to everyone coming on the call this evening to bring this to life for us. That's really helped me understand what we're doing. It sounds, fantastic pilot. We're really delighted to be part of it. Pamela, in order to kind of cascade this to some of our other teams that couldn't make it this evening, would you be able to share the video recording with me? And if everybody is comfortable to do so, I'd share that with the teams.
If I can work out how to make it work, absolutely. I take it everybody on the call today is okay with that being shared. I think it would be really useful. And I think, Scott, I'm happy to do other talks to your teams at other times, if that would be useful. Can we make it next week when I'm back at work officially? Then that would be great. Happy to do that, because what we really would like is some activity, because sometimes you have pilots and then nothing happens. What we're really looking for is activity, so that would be really useful. So the more the merrier, assuming that they're the right types of patients, obviously, but it would be really frustrating if actually we get nothing, we get a big void and nothing actually happens. And I know in other parts of Scotland they have had pilots going with the FNCs and not really getting much happening, and we're not going to learn and we're not going to be able to expand this until we have got some activity coming through. So we're really keen that we get some activity. So any patient, Laura Ann or Uzma, that you see that is suitable, then that would be brilliant, to take 5 minutes to take the details, explain it to the patient and phone it through. That will be really brilliant, because again, that's got great potential for the future about other services. And to me, it's a service that actually is beneficial to the community pharmacist standing in the store, because it gives you something professionally satisfying, that you can deal with the patient in a way that you can't do directly, but you know that the patient's going to get a really good level of care, and in the quickest pathway possible, rather than saying, I'm afraid you're going to have to go and phone NHS 24, and I don't know how long it's going to be until you get a call back from them. It could be it could be a lot longer than 4 hours anyway, that's for sure, if recent stories that I've heard anyway are anything to go by. So yeah, that's really the plea from our point of view. So Scott, absolutely happy to come in and chat to your teams about it. I'm sure that if there's any questions that I can't answer, I'll get Ed or Margaret or Charlene to give us the answers to your teams. But I think hopefully it's been a really useful summary tonight. Would
Yeah,
that be
no, it's
fair?
been
Yeah.
really helpful. Thank you.
And I mean, if any of the documentation paperwork, if there's any confusion about it, then let us know, and we can get that changed. Because obviously it's very easy for us to write it in a way because we know what we're talking about. But you know, if it's confusing, like about Laura-Ann's about does they have to be registered with a GP in Scotland? Hadn't really thought about that, but I can add that in to say that that's not a necessity. That it's not a requirement, and it's because let's face it, is sort of emergency care that we're basically providing here, so that's not the issue. So I can add that in. So I've made a note of that for the next iteration of the paperwork, I'll make sure I include that. Mark?
I was just going to say, just to reassure some of the people on the call, I think just need to go into any of the community pharmacies probably that's on our pilot list on a Saturday, and you'll see it probably is similar to a minor injuries unit at the moment. The amount of people that are looking, I'm not saying they're going to be in the cohorts of what you're looking in this particular pilot, but certainly as a very much pharmacy first point of view, and I am sure we will definitely have a number of patients coming through. And probably just a little bit of an invite if anybody is keen to come and see what it's like for a few hours in a community pharmacy on a Saturday, and the kind of patients, and maybe even help maybe shape how we could take it forward. More than happy to possibly support with that. Central Station, Buchanan Galleries, Sucky Street, wherever you would like to go. I'm sure you'll probably have your eyes opened and think, how do we get better care for these patients? And just a big thank you for me as well, particularly to Laura and Uzma, who've maybe had a hard shift in the pharmacy today and joined us. So thanks very much for that.
Okay, I would echo that. So I think I'll just bring this meeting to a close. I'm just going to work out how to stop recording, hopefully. Stop recording.